Okay, good evening, everyone. Thank you for joining us for our latest webinar series. I'm pleased to say that I'm joined this evening by Professor Andrew Morris, who's head of pharmacy, at Swansea University, as well as my colleague, Professor Neil Hartman. You're going to hear from them both now about pharmacy in Swansea, and exciting opportunities within the profession. And also we will take some questions at the end. So if you're watching this on record, then please email us if you have any questions, and the email address is study@swansea.ac.uk. Okay, without further ado, the title of tonight's webinar is Nuclear Pharmacy, when the drug is as dangerous as the disease. Over to you, Andrew.
Great, thank you very much, Emma. So I'm just going to share my screen. Hopefully you can all see my slides. So good evening, everybody. Thank you very much for joining us for this this webinar. And the aim very much is to sort of give you a little bit of a taster as to what it's like to study pharmacy at Swansea University. So the topic we're going to be talking about this evening is nuclear pharmacy or radiopharmacy. And I'm really pleased that we're being joined this evening by Professor Neil Hartman, who is head of nuclear medicine at Swansea Bay University Health Board, and is a radiopharmacist. And he's going to be able to, I think, give you a bit of a taste of what it's really like to work as a radiopharmacist within the NHS. And I know after I've given my presentation, he's got some interesting props to show, which are something which is very, very useful if you're working within a radiopharmacy. So, okay, so the word nuclear often brings up some fairly negative connotations when we hear it, and people will think about nuclear weapons and radiation. But you maybe start to think about nuclear power, and then you'll sort of realize that that there are potentially beneficial uses. And what we will hopefully show you this evening is that sort of very much there are sort of a knowledge of nuclear chemistry can actually help save lives. So what I hope to do, just a bit of a background to nuclear medicine, and then we actually need to sort of step back a little bit and think about firstly sort of what the difference is between a drug and a medicine. Then we're going to think about sort of two terms which might be quite new to you, so radionuclides and radiopharmaceuticals. And I will just touch upon the production of radiopharmaceuticals before I then hand over to Professor Hartman. Okay, so nuclear medicine is very much it's a topic which covers treatment of medical conditions, but also more importantly, often the diagnosis of medical conditions as well. I think sort of your diagnosis is probably more important than the actual treatment. And when we think about nuclear medicine, before we can actually sort of go that far, what we usually need in order to do that is employ a radiopharmaceutical. So what do we mean by a radiopharmaceutical? So before I sort of go too far into that, I think we need to actually just step back and think, okay, what do we mean by pharmaceutical in the first place? And in doing that, yeah, I think I really now need to sort of actually explain the difference between two terms that you will have certainly come across before, but they are often used interchangeably, particularly in the media. So drugs and medicines. So what is the difference between the two? So when we think about a drug, essentially we're thinking about usually a pure chemical entity. So a good definition of drugs that we often use is that a drug is a chemical substance used to diagnose, treat, or prevent disease. Now, you sort of commonly, if you were to walk into a dispensary, into a pharmacy, you would see shelves full of medicines. And those medicines would contain drugs, and usually that drug is there to treat a disease. But when we start thinking about drugs used in nuclear medicine, then that term diagnosis becomes increasingly important. So if the drug is the pure chemical, what is the medicine? So the medicine is the delivery system which is used to administer that drug to the body in a safe, effective and accurate manner. So medicines, the term is often used interchangeably with formulations or dosage forms. So the medicine is the vehicle for the drug to get it into the body. So in the example that we've got here at the top of this slide, so the chemical structure you can see there is the simple analgesic paracetamol. So that would be the drug, whereas the medicine would be the paracetamol tablet itself. Okay, so hopefully you're starting to see the difference between those two terms. So that now means we can go back and think about the term radiopharmaceutical that I mentioned before. So a radiopharmaceutical is a medicine which includes a radionuclide in its composition. Now, I gave you a definition, but now I've actually introduced a new term there as well, radionuclide, which possibly isn't very helpful. So I think what I now need to do is actually explain what I mean by the term radionuclide. So quite simply, a radionuclide is an element which emits radiation. Now, probably the most commonly or widely known of these elements is radium itself. So on the periodic table, that would have the symbol Ra. And just a little bit of nuclear chemistry revision for you now. So you can sort of see that we've got two numbers on there. So the lower number there is the atomic number. So the atomic number for radium is 88. So if it's not 88, then it's not radium, quite simply. The other number that we've got on there, 226, so that is the mass number. Now, mass numbers can vary between elements. Now, some of them will predominate, but it's quite common that an element will exist as lots of different isotopes with varying mass numbers. And some of these isotopes are more stable than others. And if an isotope isn't stable, then it can potentially decay into perhaps a different element. And in doing so, it will emit radiation at the same time. So in terms of the type of radiation that can be emitted from radionuclides, it can vary. I guess sort of three broad categories I've got on here. The one of these we will break down into sort of two sort of subcategories. But firstly, in terms of the alpha particles, so these are essentially quite comparatively large particles, equivalent to a sort of a helium nuclei in its composition. And alpha particles, they can't travel very far. They very quickly will get absorbed by just a few centimeters of air. Or if for example, your body was exposed to alpha particulate radiation, those alpha particles are just going to get essentially blocked by the first few layers of your skin. So they're not going to travel very far at all. The beta particles, they can travel a little bit further, and it's the beta particles that we can actually break down into essentially beta negative or beta positive particles. So the negative particles, so they are essentially, it's essentially an electron. And you would get sort of emission of a beta negative particle if we've got sort of excess neutrons in the nucleus of an element. The other type of beta particle is the positive beta particle, more commonly known as positrons, and these are particularly relevant in nuclear medicine imaging, and I'll mention a little bit about that in a moment. And then the remaining type of radiation which can be emitted from a radionuclide are the gamma rays. And gamma rays can potentially travel much further, hence they have a use in imaging of the body itself. Okay, so that's giving you a bit of a background as to sort of what a radionuclide is. So remember, a radiopharmaceutical contains a radionuclide. So it contains an element which emits radiation. So we're going to consider two different types of radiopharmaceuticals broadly. So I'm going to start off by thinking about therapeutic radiopharmaceuticals, and then I'll move on to diagnostic radiopharmaceuticals. So firstly, the therapeutic radiopharmaceuticals, and the most commonly cited example here, it would be iodine 131. Okay, so that's a sort of a less stable isotope of iodine. So the most common isotope of iodine, that has a mass number of around about 127. So this is a slightly heavier iodine isotope, and that will decay. And so what will actually happen? So when iodine decays, it will basically emit an electron, or one of these negative beta particles. And in doing so, a neutron is converted to a proton. So that actually changes. You can see the atomic number actually changes. So what we're left with then isn't iodine at all. We've now got a different element with the atomic number of 54, which is a xenon. So we've got that beta particle being emitted. We've got a new element created. There's actually there's a gamma ray being emitted as well, but it's that beta particle that we are particularly interested in. So when those beta particles are emitted from iodine 131 and other radionuclides that emit beta particles, and they can actually damage cells. So normally, we don't want to do something like that, but there are circumstances where we may wish to damage cells, and one example is in the treatment of cancers. So cancerous cells tend to be a lot less sort of resilient than our body's normal healthy cells. So the application of radiation to a sort of a cancerous cell is likely to be more damaging than to healthy cells. So you can see there are potential options for treatment as a result of that. So let's think about how that potentially could occur. And in doing so, I'd like to introduce quite an important hormone that our body produces, and that's the hormone thyroxine. So that's something which is secreted into our blood by the thyroid gland. So if you've never heard of that before, it's a gland which is present in the region of your throat. So thyroxine has lots of important roles within the body, involved in digestion, heart and muscle function, brain development, bone health. So yeah, it's a very, very important hormone. And I've got the structure of the hormone there that you can see. And hopefully you can see that one of the atoms present on that thyroxine hormone is iodine. So there's actually 4 atoms present in the thyroxine molecule. So what our body is able to do, it can, essentially it extracts iodine from food sources, and our thyroid gland is able to concentrate that iodine, and in doing so, thyroxine is synthesized. So imagine a situation where a patient potentially has a cancerous thyroid gland, or potentially as well, another probably more common condition that radioactive iodine would be used for is hyperthyroidism. So some people have a thyroid gland which produces too much thyroxine. So essentially what we would be looking to do here is actually somehow sort of damage the thyroid gland, reduce its effectiveness. So if we were to give a patient a radiopharmaceutical containing iodine 131 rather than iodine 127, then what our body will do, it won't really know the difference between iodine 127 and 131. So the iodine 131, the radioactive isotope, will still be concentrated within the thyroid gland. And that means that the release of those damaging beta particles becomes localized within the thyroid gland. And that, well, say in the case of maybe a thyroid cancer, will damage the cancerous cells more than the healthy cells. And in the case of something like hyperthyroidism, the iodine, radioactive iodine, essentially will sort of zap the thyroid gland and reduce its effectiveness. So hopefully you can sort of see there's one example there as to how we can use a radionuclide to treat disease. So either thyroid cancers or carcinoma, another name for cancer, or hyperthyroidism. What I will move on to now is to talk about how we can use radiopharmaceuticals for the diagnosis of disease. And this is probably the predominant use of radiopharmaceuticals within a typical nuclear medicine department. But before I sort of think about how we might use a radiopharmaceutical to diagnose a disease, let's just think about how we do other types of diagnosis. So what I'll refer to here is an X-ray. So something I guess you will all be familiar with. So let's think about how an X-ray might work. So if you've ever had an arm or a leg or something like that X-rayed, so you will know that a part of your body is placed near an X-ray source. So that's something which is external to your body. So you'll stand in front of it or put your arm in front of it, and the X-ray will basically, the X-rays will travel through your body, and they will then reach an X-ray detector, or it may have just been sort of a piece of photographic X-ray film. So in effect, what you will then see is an image of part of your body as a result of the what is stopped or not stopped by the X-rays traveling through your body. So with that in mind, I'd now like to think about how diagnostic radiopharmaceuticals can be used in medical imaging. So we've still got a patient that's sort of stood here. So the one difference you can sort of see straight away, I've already drawn in 2 detectors instead of the one that we saw with our X-ray diagram, and that's not uncommon. You could do this with one detector, but it's perhaps more accurate with two. But potentially you can have a number of detectors around. But the real difference between, say, an X-ray and imaging using radiopharmaceuticals is the source of the rays. Now, it wouldn't be X-rays in this case, it would be gamma rays. But where do those gamma rays come from? So we would actually take the radiopharmaceutical and it would be administered to the patient. Now, it might be administered to the patient via an injection, or maybe they swallow it, maybe they inhale it. There's lots of different ways of getting a radionuclide into the body. In exactly the same way, there are lots of different ways of getting other drugs into the body. But we end up with a situation where the patient has the radionuclide somewhere inside their body. But of course, that radionuclide will be emitting radiation. Now, remember, those alpha particles and beta particles are not going to travel very far, and they would potentially be quite dangerous. So the radionuclides that we would be using for imaging would be gamma ray emitters. So what you would basically see is the fact that the rays themselves are actually emanating from the patient and traveling out, and then they would be detected by one or more detecting cameras, so a gamma camera or an Anger camera, to give it another name. Now, of course, those rays won't just be traveling in the direction of the detector. They will be traveling in all different rays from the patient. So always what sort of one of the challenges in nuclear medicine has always been around, I guess, the resolution of the image itself. So what I just want to finish up really with is just sort of highlighting a particular type of diagnostic radio pharmaceutical process. That's something called positron emission tomography, or PET, or PET, very commonly known as. So that's an imaging technique used in nuclear medicine. And the key word in the title is positron. So it involves using radionuclides that emit positrons. So we're not talking about the negative particles. So not all radionuclides emit positrons. So one example of a radionuclide that emits a positron is fluorine 18 that we've got here. So just to show you how that would break down. So it would decay. You would see that there is a positron emitted, and that then sees the formation of a new element. So it's oxygen. You can see from the atomic number, that's the oxygen with the mass number of 18. So a different isotope to what we more commonly breathe in. So, okay, so the fluorine atom has emitted this positron. So what happens next? Well, that positron isn't going to travel very far before it collides into an electron. Of course, there are electrons everywhere, certainly within our body. So somewhere in our tissue, then that positron is going to collide with an electron, and that results in what we call an annihilation reaction. Now, really, in physics, an annihilation reaction is basically when sort of a particle and its antiparticle collide, and they basically disappear, releasing energy. And this is the most common annihilation reaction that happens on Earth anyway. So that's when a positron collides with an electron. Now, this is the really key thing, though. What happens after that annihilation reaction? So both particles are converted into two gamma rays, and they travel away from each other at an angle of exactly 180 degrees to each other. Okay, so they're traveling away like that. And that's key in terms of how we use this technique in medical imaging. So let's envisage a situation where instead of having one or two detectors, we've basically got a ring of detectors. Now, inside that ring, let's put a radionuclide. So we've got our fluorine atom here. So as we've just seen, that fluorine atom will emit a positron. So that positron has been emitted, and you can see the element has changed now to oxygen. Now remember, that positron is going to be traveling out. It's not going to travel that far where it's likely to encounter an electron, which it's going to collide with. And remember what happens when the collision occurs. You get that annihilation. They both disappear, and you've got those two gamma rays traveling in opposite directions away from each other. Now, because you've got that ring of detectors around that radionuclide, so if you detect the gamma ray at exactly the same time in opposite directions, then hopefully you can see from this diagram that it would be possible to pinpoint exactly whereabouts within that ring of detectors then that those two rays have emanated from. Okay, so I'll just quickly go back and show you that one more time. So we've got our fluorine atom, it emits our positron collides with an electron, and then on collision we get the annihilation reaction and the emission of those two X-rays. So allowing us to pinpoint where that collision has taken place. Okay, so now let's imagine we take that ring of detectors, and if we were to put that in a medical machine, which was large enough to actually put a patient inside, then you can envisage a situation where if we've administered a radiopharmaceutical to a patient that is a positron emitter, and then if the patient is put inside such a scanner, you can envisage how we can use this technique to actually image whereabouts within the patient's body that collision is actually taking place. Now, unfortunately, it's probably outside of the scope of this sort of short taster seminar to really go into the details of sort of, exactly how that can be used to sort of come up with different images. But that's certainly something which we'll go into a lot more detail on our pharmacy degree at Swansea. So that technique, so PET scanning is really sort of very much at the forefront of nuclear medicine imaging. It's something we're very fortunate has recently been introduced at Swansea as well. I know Professor Hartman will probably mention that shortly. So just before I hand over to Professor Hartman, I just want to finish up just by touching upon the production of radiopharmaceuticals, and this will probably sort of segue nicely into some of the things which Professor Hartman will sort of say, because the production of radiopharmaceuticals is very complex and requires specialized facilities. And the reason for that is because not only do we need to consider patient safety, because most of these radiopharmaceuticals are going to be injected into the patient, so they need to be produced aseptically. That means they're produced in a very clean environment to ensure that no microbes are present in the medicine itself. Now, that's the case with all aseptically produced medicines. But with radiopharmaceuticals, we also need to consider the safety of the healthcare professional as well, or the person who is actually preparing those radiopharmaceuticals, because we are using those radionuclides, which are potentially very, very hazardous to the pharmacist or the technician involved in the manufacture. Because if you go for a nuclear medicine procedure, you're only being exposed to that radiation on one occasion. Whereas someone who is working with these radiopharmaceuticals on a daily basis will be exposed on a daily basis, and potentially the hazard is much greater. So basically there are three principles that we need to employ when working with the production of radiopharmaceuticals. So those principles are shielding, distance, and time. I don't think I'll talk any more about that, because I know Neil has a prop which will, I think, demonstrate that very nicely. But just the final thing which I will just put into the situation to highlight is that as well as those risks related to the patient safety and the safety of the worker in the radiopharmacy, we also need to consider that radionuclides have what's called a half-life. And that's probably something that you've come across before in your studies. So the amount of radiation emitted from a radionuclide will fall rapidly. So if you perhaps compare that to the situation of maybe you were working in a kitchen and following a recipe. Now, for someone like me, who's not the greatest of cooks, I find that complicated enough already. But imagine doing that if all of the ingredients in your kitchen were suddenly halving in value, maybe on a daily or even an hourly basis. So for example, iodine 131 has a half-life of only around about 8 days, whereas something like technetium, which is a very commonly used radionuclide, that has a half-life of only 6 hours. So you can envisage that's going to further complicate the process, and that's something that we would look into in a lot more detail on a pharmacy course. So to summarize, and I'll hand over to Professor Hartman now. So we have seen that nuclear medicine that can be used in both the treatment and diagnosis of serious diseases. We've seen that these procedures usually require a radiopharmaceutical, and they have a radiation-emitting radionuclide at its core. And then finally, that the manufacture of radiopharmaceuticals requires highly skilled staff and specialized facilities. So I think now at that point, I will hand over to one of these highly skilled staff, Professor Neil Hartman from Swansea University Health Board. And I will leave him to talk to you now really about what goes on in reality within a nuclear medicine department. So over to you, Neil.
Thank you very much, Professor Morris. Very nice speaking to you tonight. I am head of nuclear medicine at Swansea Bay University Hospital, and one of our biggest nuclear medicine departments is right next to the university campus. So we have quite a varied group of professionals in nuclear medicine. We have medical doctors who report our scans. We have technologists and radiographers who actually scan the patients. We have quite a few physicists who look after radiation protection and the quality and functioning of our scanners. And then we have the very specialized group of radiopharmacists and radiopharmacy technicians who make the radiopharmaceuticals. We also, I hasten to say, probably have at Singleton Hospital the most modern radiopharmacy in Wales. So it is quite a special facility, which we're very proud of. When I give talks about radiopharmacy, many students ask me, so how do we become one of you, Neil? And I'll tell you my journey. Your journey might be very different. I am young enough that I started pharmacy school quite a few decades ago. And I did my pharmacy degree and thought of specialization and decided that radiopharmacy or nuclear pharmacy was indeed something very interesting and different. As one of my early professors said, Neil, if you study radiopharmacy as a pharmacist, you will be a big fish in a very small pond. And that's quite true. There's about, I would hasten to say, 30 to 40 radiopharmacists or radiopharmaceutical scientists in the UK. So what do we do? And I am going to tell you a few bullet points of what we do by comparing it to normal pharmacy. The first thing that's very different in what we do is the hours we work. I think one of my new colleagues is on in this webinar as well. We start very early in the morning. We typically start between 5 and 6 a.m. That might shock some of you. The good news is that gives you enough time to play a round of golf at the end of the day when other people are still working. Why do we start so early? Well, several reasons. One reason is this very short half-life of many of our radionuclides. If we consider the humble technetium-99m with a half-life of 6 hours, you can see that we have to make new technetium radiopharmaceuticals every single day. So that's what we come and do in the morning. We have a production run between 5 and 9 a.m. where we make our radiopharmaceuticals. And then around 8:30 in our situation, we have lots of transport vehicles which take the radiopharmaceuticals to other hospitals. The transport of radiopharmaceuticals, which I won't go in tonight, is also very different from normal medicines. So number one, the big difference is we start much earlier in the day. Number two, which Professor Morris alluded to, is not only do we need to think about the sterility or aseptic manufacturing, we also need to think about protecting ourselves from the gamma rays and occasionally from the beta minus rays that we use to manufacture radiopharmaceuticals. So there are many things we do to protect ourselves. We all wear personal dosimeters so that at the end of the month, we know how much radiation we received. And I'm happy to tell you that we typically receive less radiation than the average background in the UK. There are many natural ways in which all of us receive radiation on a daily basis. Another way to protect ourselves is, as Professor Morris explained, by distance. We stay far away from the radioactivity, so we use tongs to hold anything that's terribly hot, and by hot I mean radioactive. Another way is to shield ourselves, and I do not know whether you can see, but in my hands I have a 10 milliliter syringe surrounded by a lead shield. And this is the lead shield. You will see two things. There is a lot of thick lead, and there is lead glass so that I can read through the lead glass how many milliliters I have in the syringe. So this protects ourselves from gamma radiation and beta radiation as well. So the whole issue of protection is point number 2, different from normal pharmacy. My bullet point number 3 is we have to be very quick. If you think of your average aspirin tablet or paracetamol tablet, you would probably have a shelf life of many, many months and most probably several years. Our radiopharmaceuticals have at most a shelf life of a few days, but more often than not of a few hours. And what Professor Morris didn't share with us tonight, there are some radiopharmaceuticals with shelf lives in the seconds. And we all use them as medicines. We all have to be certain that they're sterile and fit for purpose, and we have to be quick. So that's a very big difference. I guess a fourth point of difference from normal medicines is that in radiopharmacy, the way we release medicines for patient use is very different as well. If you've ever visited a pharmaceutical company, you will know there's a huge quality assurance team that release the medicines, the tablets, or the IV fluids that's been made, and only then are they shipped. In radiopharmacy or nuclear pharmacy, we quite frequently do something called parametric release. We don't have enough time to do all the quality assurance. We do some of it, ship the radiopharmaceuticals to other hospitals, and then continue our quality assurance and make sure that the products are fit for purpose. I will say one more difference with normal pharmacy, and that is that 99% of all medicines used in radiopharmacy are indeed injectables. We make vials or we draw the radiopharmaceuticals up in syringes, and they are given to the patients mostly in the antecubital fossa of an arm. I'm going to end with one more difference. In normal pharmacy, we count tablets, or we count volume, or we count weight. We can do neither of those in a radiopharmacy, and we have to put the vial into something called a dose calibrator that measures how much radioactivity is in the vial we prepared. We then ship that vial to other clinical departments, nuclear medicine departments, and they have to draw up each patient dose and again measure it in a dose calibrator before they give the patient the required amount of radioactivity for their diagnostic scan, or indeed for their radioactive treatment. So in a nutshell, radiopharmacy is exciting, it's different, we enjoy the difference, and it's a very exciting specialty in pharmacy. Thank you.
Thank you very much, Neil. That was fascinating. I found it particularly fascinating as well, and I hadn't appreciated how early you have to get up as well in terms of that medicines production. I can see there is a question has appeared in the chat, and whether it might be something that you might want to answer, Neil. So the question says, would the kind of annihilation reaction caused by PET technology be harmful to a patient For example, if the electron that the positron collides with is part of an atom in the cell structure, would the change of charge result in changes in cell structure? So do you have any thoughts on sort of the safety of PET?
Certainly. I will say the following. The most dangerous type of radiation is indeed alpha radiation. Those of you who are interested in world politics will know that a Russian spy, Mr. Litvinenko, was given some alpha emitter, we think, in his tea. He also contaminated various doorknobs in London, and he died at a London hospital. For many, many days, we didn't know what he was given because we couldn't detect it outside his body. It was blocked by his organs. That's alpha radiation. The next dangerous, less dangerous type of emission is indeed beta emission. But we are typically concerned about the harmful effects of beta minus emission electrons. Positrons travel also a very small distance, but because they combine with free electrons, there is very little harm, and they then give off very high energy gammas. So if there is a concern of safety, I would say the safety is more the fact that we have a very high energy gamma going through the patient, and as Professor Morris explained, at 180 degrees of each other. Curiously, a fluke of nature, both these annihilation gamma rays have the same energy of 511 keV, which is fairly high. Technetium, which we use in 80% of our imaging, has an energy of 140 keV, so roughly 3 times less, so 3 times less damage to cells. May I just say, Professor Morris, that unlike normal medicines, we deal not only with biological half-life, but also physical half-life. So typically the excretion or the disappearance of a radiopharmaceutical from the body is a bit faster. We have something called the effective half-life, which is a combination of both the biological half-life and the physical half-life, and both work together in the pharmacokinetics to help the radiopharmaceutical disappear.
Great. Thanks for answering that question, Neil. And I think probably you'll be best placed to answer the other question we've got as well, and that is there a need for more radiopharmacists?
Absolutely. I joked early on about my youth, but there is a real concern in the radiopharmacy community for succession planning. Quite a few of us are getting on, and we continuously look for new radiopharmacists. There are also opportunities I'm working on with Welsh government and the UK government on new large radiopharmacy facilities in Wales or otherwise in the UK, where we will need radiopharmacists.
So I think that's a very positive answer. I think so. There's definitely a career there. And then I guess sort of a follow-up question to that: is it difficult to get into nuclear pharmacy?
Curiously, there is no proscribed route into nuclear pharmacy. So we want someone with typically pharmacy background, but there are production managers in radiopharmacy with a other scientific background. And your experience is much more important, your experience of radioactivity, radioactive medicine, than anything else. So if you have an analytical, curious mind, you are made for the job. I also always tell my London students, and this is just fact, that because of the scarcity of radiopharmacists, you will find that their salaries are commensurate with the scarcity. So the starting salaries of radiopharmacists are typically quite a bit higher than that of junior pharmacists.
And I'm sure those of you that are joining us who have applied to pharmacy and then thinking about specialism, I'm sure they'll be excited to hear that. That's great news. And I just want to say thank you both for tonight's webinar. We'll just give it another moment or two to allow those that are joining us live to type in any more questions in the Q&A. And we have had another question come in actually. So it's we've had a question. So would it be necessary to get a PhD in radiopharmacy in order to work in nuclear pharmacy?
No, not at all. You will find that a PhD gives you the experience of research and knowing how to investigate certain problems, perhaps how to do clinical research, how to approach pharmacokinetics, which is quite often an experience you just don't have time for to get in that depth during your pharmacy education, but absolutely not, a PhD is not necessary to become a radiopharmacist.
Okay, fantastic. And just to remind those of you that are watching with us live and those that are watching this on record, we did have a webinar a few weeks back as well, specifically for those of you that are interested in pharmacy, and that was with our colleague, Dr. Gurgis, and she covered a pharmacy presentation where the recording is on the webinar page, Head Starts, and that was on counterfeit drugs as well. So you'll also find that on the page where you registered for tonight's session, and we make sure that link gets sent out to everybody again following tonight's session. So I'd encourage you to watch that session as well. Another question's come in, so probably to you, Andrew, this one. Will there be placements to see radiopharmacists as part of the course in Swansea?
Yes, so I should point out, so, and I perhaps didn't make this clear at the start, so Professor Hartman is head of nuclear medicine at Swansea Bay University Health Board, but he's also an honorary professor within the pharmacy department at Swansea University as well. So there will certainly be sort of opportunities related to, it might be that Professor Hartman delivers a lecture where we're exploring options to look at a radiopharmacy visit as well. So there certainly will be, I think, a variety of different options to, I think, explore your interests and knowledge of radiopharmacy and nuclear medicine.
And Professor Morris, if I may add, I certainly have a hope that there will be opportunities for those who are very interested in radiopharmacy or nuclear pharmacy to do small summer projects or drug development, etc., with us in radiopharmacy. At the moment, a colleague of mine who's in the webinar and I are doing a UK first, probably a world first investigation with regards to a new diagnostic agent, radiopharmaceutical, for prostate cancer. So if there is anyone interested in looking at stability, manufacturing of medicines like this, we would welcome them for a few weeks to join us in the radiopharmacy.
Well, it's great to hear that those opportunities for sort of vacation researcher potentially there as well. So, and I'm certain that type of opportunity would definitely enthuse a number of pharmacy students. Thank you.
Thank you very much. Okay, that brings our session to a close. All that leaves me to say is thank you so much to Professor Morris and also to Professor Hartman. Thank you both for joining us and sharing that fascinating webinar, and also hopefully inspiring and enthusing those offer holders that we have for pharmacy this year at Swansea. So a reminder to anyone, if you are yet to apply, and you would need to find out some more information, then please do email us. And the email address, as I said earlier, to use is study@swansea.ac.uk, and myself or the team will get back to you as soon as we possibly can. Okay, thank you ever so much for joining us.